primary osteoarthritis, and the other one is secondary. So if you look at the primary component of this, as I mentioned, it is written as a normal degeneration of a joint. Okay. So why do I write a normal degeneration? Because it is a wear and tear that occurs of the joint. So tomorrow, if I always tell people that, or when I have to explain it to them, that imagine you have a brand new car and you have a set of wheel. So what happens is that the wheel is thick, it's got good threads, but as soon as you start driving the car, the wheel is getting used, and the more you use the car, the more the wheel gets worn off. So the similar thing happens with most of our joints, especially what is known as the weight bearing joints. So the hip joint, the knee joint are areas where the whole body's weight lands on it. So therefore the wear and tear is higher in those joints than say compared to say the elbow or the shoulder joint. So that is why the primary osteoarthritis is a normal degeneration of the joint. Here the joint, as I mentioned, is a healthy joint. There is no problem with it. Okay. And there is no proper cause. So they always say it's an unknown cause. It's just normal wear and tear. Some people, rather most people, develop this symptom after the age of 55, 60 years old, where they start to develop knee pain. And the second type is known as the secondary osteoarthritis. So secondary is where there is a pre-existent condition or some problem that has occurred prior, because of which the joint has now developed arthritis early. So it could be anything from say, a trauma. If you had what is known as an intra-articular fracture, so where you have a fracture and it has caused a problem within the joint, or if there has been bleeding into the joint, or if you had some kind of a ligament injury, which like the ACL, PCL, any of these injuries which occur, which causes more wear and tear of the joint as you go forward in life, as you progress in life. So anything that causes degeneration of the joint to happen faster is usually termed as a secondary arthritis. So the most common joints that have arthritis is usually the hip, knee, and the spine. So as I said, most of the times the weight bearing joints are usually affected. Usually, if you look at the general population abroad, the most common joint that they say is usually involved is the hip joint. But in India, it is often seen that the knee joint is the most commonly involved. And there are various studies which point towards the fact that Indians usually use Eastern the toilets. So where you have to sit down and squat for a long period of time. There's a lot of, we sit with our legs crossed, or we sit with most of the times where our knees are more than 90 degrees folded inwards. So there's a lot of pressure on the knee joint, which causes a degeneration and wear and tear to happen faster. So very simple, what happens is, because of this wear and tear, there is something called as a cartilage, which is present over the bone. So if this is the bone, there is something like a covering over it, which is called as a cartilage. And this cartilage has no nerves. So therefore you don't get any pain whenever the two bones rub against each other, because each bone is covered at one end with a cartilage. So when you walk, these cartilages rub off against each other, and there is some amount of lubrication present within this, which allows you to walk pain free. But as the wear and tear occurs, if the cartilage is so thick, and as the wear and tear occurs, the cartilage starts to thin down to a point where then the bone gets exposed. And once the bone gets exposed, you start having pain, because the bone has a lot of nerve endings. And this is what gives you the sensation of pain. So these are photographs, for example, where in photograph A, you will see this white color thing is the bone and the cartilage that's present over it. And the central part is where the cartilage has gone. Okay, you can see the same thing in picture B. And then see there is a more clear picture. This shiny, glossy white thing is the cartilage over the bone. This little, ivory color below that is actually the bone itself. The cartilage covers it. And right over there where my pointer is showing, that is the area where the cartilage has gone. So therefore, when a patient will walk, because this area has no cartilage covering, the patient starts to develop pain. So as I said prior, this is how on the left hand side, you'll see a brand new tire and you have good threads and gives you good grip. The tires go, but say if you run the car 30 to 40,000 kilometers After this, what you will realize is that there is a flattening or wear and tear of the tire. So what happens when this occurs? If you go to a garage, they will tell you, sir, tire change karna padega. We have to change the tire. And that is why there is something similar what we do also, where you do something called as a replacement. But just like the tire, if you look at this, when a wear and tear occurs, it does not occur evenly. So if you look at the right side of the picture, it shows you that the central part of the tire still has its threads, while the corners have got more worn off. So something similar happens even in our body. Most of the pressure is borne on either sides and not centrally. So I'll show you an X-ray, for example. What you can see in this X-ray in part A is that you have a bone on top and you have the bone below, and this forms the joint. So now, if you look at this, there is a clear space over here. So it's not like as if the space actually exists in the body. But what happens is that in this area, you have something called as the cartilage. So the cartilage is actually present like this over the bone. And you have, from this part of the bone, you have another part of the cartilage that lies over like this. So this space is actually consisting of the cartilage. But because you cannot see it in an X-ray, it shows as a space. So that is one of the things that we usually see during an X-ray. We look at the space and we see the measurement. How big is it? So if you look at it, the more it starts to progress, you will see that the space has reduced over here. So this is an indication or an indirect indication of the fact that the cartilage has thinned down. Now look at picture D. It shows you clearly compared to picture A, where there is so much space, there's hardly any space left. So you know that the cartilage has completely gone and the bone is now making direct contact. So this is usually a feature of or an indication of arthritis to have set in. Now what happens is that you have other things that we also see, like for example in picture B, you can see this arrow pointing to something of a bony growth that has come out from the sides. Same thing in picture C and D. That is known as an osteophyte. So that is what the body tries to heal itself. But since the cartilage cannot grow back to what it was, you can once it is lost, it can never come back. So the bone tries to grow at that point of time. So these are other indications that you will see, which are known as an osteophyte. So what are the risk factors? Because at the end of the day, if something is going to happen, what we should know, what are the factors that cause it to come to us faster, or that we see it sometimes developing in a 35 or 40-year-old person also. So one is, as I mentioned, trauma. So trauma is very, very important because especially in the younger population, arthritis starts to set in early if they've had a previous history of trauma. So most of the youth, either they've had a road traffic accident where the knee has got injured, or you have sports injuries where they are playing football, cricket, and they've twisted their knee and they have now got a meniscal tear or a collateral or a ligament injury. So what happens is that within the knee joint, there are, apart from the bones, there are a lot of soft tissue present within it. So you have the ACL, the PCL, the MCL, LCL, the meniscus, all contributing to the knee joint, and all of them have something called as they contribute in the stability of the joint. So what happens is that when these things get traumatized, when the soft tissue gets traumatized, there is a instability now in the joint, which causes further wear and tear. Second can also be a direct impact during a fracture. So the last point what I was mentioning is biomechanical is similar. Whenever there's an instability that occurs, you are more prone to develop osteoarthritis faster. The second thing is obesity. So naturally, uh, as I mentioned, say supposing we take the prior example where we're in a car and you have 4 brand new tires, and imagine that you are the only one driving the car. So your tire will now run up to 40,000 kilometers a day in its lifetime without having any issues. But supposing if on a daily basis you carry 5 people and there's another 30-40 kilos luggage. So what happens is because of the excessive weight now in the car, the tires get worn off faster. So instead of 40,000, now its life has now reduced to say 20 or 30,000. So same way obesity causes an excessive load on the knee joint. So usually on the hip and the knee, when you're standing or when you're walking, or at one point of time, you almost have 6 times the body weight on one joint. So the wear and tear is faster because of the excessive load. So therefore, obesity is one of the risk factors. Age and sex again. So usually age because, as I said, anyone above 55 is more prone. It's already started to develop. They start having the pain earlier if they have an injury prior to that. And sex is very, debatable topic at times, because they say that a lot of men get osteoarthritis faster because they are more physically active. They have more of they're manual laborers, so there's more joint stress that's occurring at one given point of time. But it's also seen that in women sometimes you can have it in the smaller joints like the hands. So again, occupations is another thing. Occupation is like wherever you have anything where it's excessive wear and tear. So if, for example, a footballer will have more wear and tear in the knee joint. Genetics to some extent, and you have biomechanical, which I mentioned. So in all, in a very small, in a nutshell, that I wanted to tell you was, you have two types where the joint is abnormal. So either there is a problem. Sometimes people have flat feet, and flat feet can contribute to the difference in the biomechanics of the body, which causes more stress on the knee joint, and that can cause abnormal stress on a normal knee joint, can cause wear and tear. Or what happens is that the joint itself is abnormal, but the stresses that you're getting on a day-to-day basis are normal. So what happens when you age is a very simple thing to understand. The cartilage is like an elastic band or like a rubber band. And every time you walk, what happens is that it compresses the cartilage, and the cartilage absorbs the shock along with the meniscus that is present. It absorbs the shock and it pushes back and gives some amount of resistance. So for that, there is a lot of water that is present within the cartilage. But as you age, what happens is that the water gets reduced. And whenever the water reduces, the cartilage and the meniscus becomes more harder. And the more harder it gets with age, the more it is prone to damage. So what happens is that as you grow old and the water content reduces, because the damage is increased, your chances of getting arthritis also increase. So we come back to the most basic things. Say, supposing if you have to look at yourself at home, or you're looking at a grandmother or someone in your family or yourself, and you think that you have these issues, what are the things or the signs and symptoms that you will see? So the first thing that you will notice is pain. Naturally, as I mentioned, the cartilage has gone, the bone is exposed. So every time you walk, you run, you are going to develop that pain in the knee joint. So pain is the first thing that happens. Then there's something called as crepitus. So crepitus is a medical term for grinding. So just imagine if you've taken two stones and you rub two stones against each other. So the kind of grating noise that you get is something that you will feel within the joint. So medically, what we can do is we put our hand over the knee joint and we just ask them to bend, or we ourselves just flex and extend the leg. What happens is that we get a grating sensation that we feel with the hand. So that is known as crepitus. So that is an indication of the cartilage being worn off, and now the bones coming in contact with each another, because of which you get that sound. Deformity, which I'll show in the next slide, and stiffness. So stiffness is something that patients will come up and tell that when I get up in the morning, I cannot move my leg, or I cannot move my hip, I cannot move my back, my hand. It lasts for at least 30 minutes, but it doesn't go more than 30. Usually in osteoarthritis, it doesn't last for more than 30 minutes. It's there for as soon as they get up, or when they're sitting inactive, dormant for a long period of time, and they suddenly get up, then for the next 20 minutes, they feel a stiffness in the joint. After which, when they do some amount of activity exercise, it becomes, better. So that is the kind of complaint they'll give. The other thing is what I said was deformity. So you'll see this quite often. If you look at your grandmother, your grandfather, or even if you are above 60, 65, you will notice that the legs are usually not straight. They have some amount of deformity. So in the first picture on the left-hand side, you will notice I've drawn two reference lines that go along the top half, the femur, the thigh, and the lower leg. And you can see that the knees are almost touching with each another, and the leg are wide apart. The other kind of, this is known as a valgus deformity. medically. The other one that you see is a varus deformity, which you will see in the second picture, where the legs are coming together. It's the opposite of the first picture. And the same patient, if you look at him on the right hand side, okay, this is post surgery where the leg has now been aligned after he's been operated. Okay, so you can see the deformity clear in the left in the second picture, which has now been corrected post surgery in the third picture. So what we do during surgery is we try to get back the normal axis of the biomechanical axis of the body, of the knee joint in particular in this case. So how do we diagnose? So when you approach me or any doctor, the first thing that they ask you is your history. What is the problem that you're having? Do you have pain? Is the pain there for the whole day? Is it occurring more in the morning? Is it in the night? We have our questions which, along with your history, we look at these, we try to push and find out what the problem is. So history, then the signs and symptoms, as I mentioned before, what you complain of and what we see is what constitutes the first point. Second thing is X-rays, like the X-ray that I showed you prior. We come to know a lot with the X-rays. You don't necessarily need a CT or MRI to give you a basic diagnosis of arthritis. An X-ray suffices and is probably the best investigation at that point of time. The other thing that we do is blood tests. So supposing if you need to look at someone who's got rheumatoid arthritis, it is easier to detect that with a blood test. Okay. And something which is a fourth point is something called the joint fluid analysis, where we take an injection and we withdraw some amount of fluid from the knee joint and we send it for analysis, and it gives us a clear picture of what the problem lies. Okay. So the same thing as I mentioned prior, in an X-ray, you can see the same joint space that is present on both the sides, which has now progressively reduced to a point where it is almost touching. Okay. And because of that, you can also look at the bone on top has also got some amount of changes now because of the damage. So what happens is that the space is reduced. There are these osteophytes that I mentioned prior, and because you have continuous bone to bone contact, what happens is you can develop something called a micro fracture, which is a small fracture that occurs, because of which the bone then starts to heal again and then the pain remains. So coming down to the more important thing is, what is the treatment? So there is no cure, because it is going to eventually happen. That's why I said arthritis is an eventual pain. Osteoarthritis will occur. It is a normal wear and tear and degeneration of the body. So there is no proper cure. But what we can do is we can slow down this process of degeneration. So there are ways of how you can control it so that, or you prevent it, so it doesn't occur to you at the age of 55 or 60. It may occur at 70, may occur at 80, or if you're healthy, then you may not have that issue at all. So there are two lines of therapy always. The first thing is always we give is, all doctors will tell you to do a conservative line of therapy. We don't advocate for surgery for every case unless you have come to us in a very bad condition. There's extreme pain, there's a lot of deformity, and conservative therapy will not benefit you. Then surgery is an option. But anyone who comes to us, the first thing that we usually do is a conservative line of therapy. So what happens, or what are the things that we do in conservative? So the first most important thing is physiotherapy, and not many people understand the importance of it. But physiotherapy is the mainstay and our right hand for orthopedics. Physiotherapy is like a right hand. It is very, very important that many patients don't understand. They think that it is just a simple exercise and a physiotherapist will come once or twice and they now know it. So they don't do it later on, or they don't call them. But physiotherapy is very, very important, because I have seen it personally that when a physiotherapist is there, the patient responds better. They push them to do better. And the results are always better when someone's there. It's like your own physical trainer at the gym. You will always do better with them. So a physiotherapist is important. The second thing is lifestyle modification. So if you weigh 150 kilos, the first thing I would advocate is to reduce your weight, because the more heavier you are, the more is the pressure now acting upon the joint, and the wear and tear is going to become worse. So the first thing that I would say is lifestyle modifications, like doing some amount of exercise in a day, looking at reducing your weight, getting as healthy as you can, improving your diet. So diet is a very important role, increasing calcium in your normal daily foods, green leafy vegetables, having your vitamins and minerals. If you're above the age of 55, 60, look into that because that's very important. Second, the third thing is analgesics. So analgesics is basically painkillers. But the thing is that a lot of patients come and they keep having, because the problem has now occurred and the pain is continuous, they keep taking pills. But that is also not good, because the more you take the medicines, the more problematic it becomes later on for your kidney and liver and so many other problems that develop because of that. So gastritis is the most common thing, where you have acidity, for example. In the most simpler way is acidity, what people say, or they have a burning sensation in the stomach or chest. Third, another problem is you can have kidney failure. So taking medicines is only good enough to reduce the pain for that point of time. But physiotherapy and lifestyle modifications are the mainstay for your treatment. And then the fourth point I've written is intra-articular injections, and I put in a question mark because it's a mixed, it's a rather a debatable topic. A lot of people advocate it, and a lot of people don't. And I have experience with both sets of doctors. But there are certain things which have shown beneficial. Something like an injection with hyaluronic acid has known or has shown to be beneficial, but it doesn't last long. It lasts for 3 months, 6 months. So you need to continuously take these injections. Some people also advocate steroids, but steroids in weight bearing joints at least have some amount of problems because they cause more erosion later on. But say supposing if it's in the shoulder joint or the elbow joint, it is known to be beneficial. So it depends on your doctor's advice and each patient, and how everything can be customized accordingly. So what are the lifestyle modifications that I mentioned is weight loss. So as I said, weight loss the right way. Don't starve yourself for 10 days, not eating right and not drinking enough water, not eating enough food. Do it the right way. Small meals multiple times, or whatever your doctors or your nutritionist or your physician advises you. You should lose weight the right way and come to the optimum weight that is required for your age and your height. Second thing, as I mentioned, is exercise. The third thing that I always tell people is avoid sitting cross-legged. So if you are old or you have developed knee pain, I would advise you to not sit cross-legged. Always sit on a stool, always sit on a chair. And whenever you do sit, avoid bending your knee for more than 90. So if this is the knee joint, avoid bending it for more than 90. Always try to keep your legs as straight as you can. So it puts less pressure on the joint, including the patella. And there are certain exercises that physiotherapists and we advocate, which is very important for you. So supposing if you're sitting at home, there are certain exercises that we give. So one is known as a quadriceps exercise. So if you see in the first picture, we put a pillow, or you can roll a towel and just keep it below your knee joint. And one way is, once you put the pillow or the towel below the knee joint, you press it down. So if this is your pillow and this is the knee joint, you press it down like this while you tighten your quadriceps, your thigh muscles, and you hold it for 10 seconds. So you hold it down 10, 9, 8, 7, and then after 10 seconds you release. Wait for 3-4 seconds and repeat it. Do this about 20 to 30 times a day. The second one is a hamstring set, where you in the same posture you can press down and you pull your legs, okay, where your heel is pressed down against the ground, and while you physically pull it with your hamstring muscle. The third one is a straight leg raise, wherein in the same posture you raise your legs straight up and hold it there for 30 seconds or 10 seconds. Bridging is where you do the same posture, lying flat with your knees bent at 90 degrees. You will raise your hip up. So if you see the hip is not touching the ground, you raise your hip. This is for the lower back and your hamstrings. The fifth one is a knee extension, which is as simple as it sounds. Sit on the chair and then you just extend your leg, contract your muscles at all point of times, hold it for 10 seconds. Sixth is a heel raise. Seventh is your butt kicks. So if you have a physiotherapist, I think he will be able to do these exercises with you better. The other one, which is a very good exercise even for younger populations, because sometimes I've seen that the older people cannot do, is what is known as a wall squat. So you take a medicine ball, but since most people do not have a medicine ball, the second picture, which is on the right, what you do is just imagine there is no medicine ball. You can do this facing the wall. So you put your back against the wall and you just squat down. Squat down till your knees are about 45 to 90 degrees, but don't go below 90, and hold that position for 30 seconds. And that is a very, very good exercise for your knee joint. So it strengthens your quadriceps, your hamstring, and helps in reducing the pain. If all of this fails and the pain is still very severe, or you have come to a point where you cannot, conservative therapy does not do well for you, then surgical option is the best. And what the term is, what we use is an arthroplasty. So arthro, as I mentioned, is joint, and plasty means to change. That's why plastic surgery comes from here. So basically arthroplasty is basically where you do a joint replacement. There are a lot of other surgeries that you can do. You have an HTO, I mean, or a condylar replacement. There are a lot of things that people advocate, but the best results are usually seen with arthroplasty. Now, the thing is that for a joint replacement, if you do come under the criteria, most of the people that we do it for have to be usually above 65 years, because the life span of this joint or this implant that we use is usually 15 years. A good implant may last you 20 years. So if you do it at the age of 40, 45, then you have to do another surgery at 60. So therefore, we don't advocate it to anyone who is usually less than 65 years, because then the implant lasts them up till the 80, 85 at least. So therefore, a replacement is usually advocated for someone older. So if you do have a lot of problem with an arthritis and you're young, then there are other surgeries that we mentioned, or conservative line of therapy is always better than a replacement. The second time, which is a little less common compared to osteoarthritis, something called rheumatoid arthritis, and usually it is most commonly seen in women and involves the smaller joints. So you'll have joints of the fingers is the most common things. You'll have the joints of thumb, where they have these complaints of this pain. They get up when they get up in the morning. There's a slight stiffness. They can't open. Their hands are contracted like that, and it takes them more than 30 minutes compared to arthritis, where it happens less than 30. It takes more than 30 minutes for them to open up. So they have to keep doing some amount of exercise, or they have to keep their hand in warm water, and then they feel relief in pain. So this is a rheumatoid arthritis. So here it is slightly different. It's not a normal wear and tear. It is what is known as an autoimmune disease. So an autoimmune disease is where our own body's cells attack itself. Okay. So therefore, these cells attack your body's what is known as a synovium in the joints. There is a covering in the joint called as a synovium, and it attacks that area. And because of that attacking, it causes inflammation, and there is a destruction of the joint. This is an unknown cause, but there are a genetic component which is known as an HLA-DRB1 gene, for example, is one of the reasons that some people develop. So people who have rheumatoid arthritis in the family, it can be passed on to their children also. So as I said, it is slow, again insidious over weeks, months, years, but in less than 10% of people, it can occur very rapidly. Within a month or two, they can have all the symptoms. There's a lot of warmth. If you feel the joint, it'll be warm, it'll be painful, the joints will be red, and there's a stiffness like I mentioned. And because of this, they have a lot of muscle weakness, and they have something called as an ADL. Is what is basically an activity of daily living. So if you look at a person, can he do his work with this disease? If he can do his work with little pain, that means that it has not affected him that badly. But tomorrow, if he says, I cannot get up from bed, I cannot do any of my work, I cannot go to office, then that gives you an indication that the problem is very severe. Okay. So again, here the treatment is conservative, is always the mainstay. You have to try to control the problem. So analgesics is painkillers. We give painkillers to control the pain. We start with something called as DMARDs, which is basically disease modifying drugs. So methotrexate is the first one, for example, is a beautiful drug that works for this. It's now advocated as a first line of therapy. If a patient is diagnosed with rheumatoid, it's always a good drug to give. It has a lot of side effects, but the benefits that it gives or it provides is better than the side effects that you are seeing. So methotrexate is one, steroids is another thing, and immunosuppressive drugs. All of these are mainly given so that your immune system comes under control, because it's your immune system that is attacking your own body. So you're trying to control that aspect. The third thing is physiotherapy, the same things which I mentioned prior. But again, depending on the joint involved, the physiotherapy changes. And if all of this fails, then the next thing would be surgical, would be something called as a synovectomy. So since the problem lies in the synovium, as the immunity or your immune cells are attacking the synovium, you do a synovectomy, but that doesn't give you good results in the long term. And the second option is what is known as a joint replacement. So that concludes my talk with you guys on arthritis. If you have any doubts regarding the same or any problems, or if you need to contact me for the same, you could call me up on that number or send me a email on that email ID. Thank you.
Thank you, Dr. Rishabh. I think it was a very well done session, and also a lot of insights on the topic. At least for me, I think one big thing that at least I figured out is there's no cure. You can actually only delay the process. So there are some questions that have come in the chat window. So I'll read them out one by one, and then maybe you can respond to them. The first one that's come up is that how can one avoid getting knee issues in the old age? Are there any exercises or precautions?
Okay, so this question was something that I just spoke about. There are a lot of things that can be done to prevent the same. So let me just go back to the slide. That's my previous slide. So as I mentioned, so if you're already old, okay, say 50 years, 55 years, 60, because today what we are also told is that being 70 is not old. My grandfather, who used to run at 80 years, used to run on the beach 8 kilometers a day. He's completely fine. If I try to run with him, I won't be able to keep up. So we have something called as a physiologically old. So there can be a guy who is 40 years old, who's obese, who doesn't do any activity, sits at home, and there is a 65-year-old guy who runs around, does treks, and still is more active than the 40-year-old. If you look at the age, the guy is 65 is naturally older. Okay, but the problems will be more compounded for the guy who's 40 doing nothing, obese with so many comorbidities. So therefore, there is a difference in when we say as old age. Okay, so if you need to prevent, okay, as your question says, how do I avoid getting knee issues in old age? So if you need to prevent it, there are a lot of ways, right? So one example what I mentioned was weight loss. If you are overweight, then losing some amount of weight in the right way is always advocated. Exercises. So the exercises that I mentioned over here, for example, are something of the same. Quadriceps sets, hamstring sets, your straight leg raises, your bridging exercises, all these contribute to preventing the problem from occurring. And I know a lot of people who've been doing these exercises for a long time, and they are 65 years old right now, 70 years old with no knee pain at all. Okay. The other thing would be, as I mentioned, avoid sitting cross-legged whenever you can. And if you do sit up at a platform, then always try to keep your legs straight. Don't bend it too much. Don't bend it more than 90 degrees. Okay.
Thank you. The next question is there any relation of deficiency vitamin C and D with arthritis?
Okay. So vitamin C is basically a very, very important, you can say, is a component for something called as collagen. Okay. So, and collagen is present in your teeth, in your bones, in your gums, and it is required for blood clotting. There are a lot of important things that occur because of vitamin C. So when a person has a deficiency in vitamin C, you are going to have joint pain. The same thing is with vitamin D. Vitamin D is a very important hormone which controls the amount of your bone metabolism, basically the strength of the bone, how much calcium is deposited, how much is taken out is controlled by that. So both of them contribute to bone metabolism. Now, if there is a very severe deficiency, only then, and for long term, so if you've had this deficiency for 3 years, 4 years, and then there are going to be bony changes seen, then you are going to develop joint pain. But if it's just over a short period of time, you will develop that pain, but it can be taken care of easier. Now, a lot of people in India, if you take a random test of 100 people, everyone's going to have a deficiency of vitamin D, because anyone who's comes to us and we check a vitamin D test, they all show it to be 22, 23, 24. Some people are 16, some people are 18, while the normal criteria that is shown is above 30. But you must remember that we had done a study, okay? So I had done a study wherein we noticed that when vitamin D was taken in the general population in India, the values are different from the international values, because what happens is we and Indians are darker skinned. So because we are dark skinned, we have something called as melanin in our body. So that prevents the sun rays from getting absorbed. And sun rays is a very, very important factor for vitamin D to what do you call it, be produced in the body. So in general, when you look at it, people are going to have a lower value. So our study showed that anything above 20 is normal. Even though international standards say 30, even above 20 to 30 is normal. The deficiency below 20, and if severe deficiency is below 12. So if you have vitamin D deficiency, then I would advocate you to take vitamin D capsules. Okay.
And thank you. The next one is, does walking, running, cycling add to further degradation of the knees, or it helps in preventing or delaying the process?
So again, walking, running, cycling are activities that, if done right, do not give you any problems. So the thing is, for example, running, it is always known that if you run on a softer surface, if you run on sand on the beach, or if you run on grass or mud, it is better for the joints than if you run on concrete, if you run on tar, because they are softer. So what happens is that when you run on, say, supposing grass, compared to when you're running on the road, the impact is more onto your joints when you're running on the road. So that causes a lot of pain in the long term, compared to whenever you're running on the beach or when you're running in the garden. Okay. So the surface on what you run is very, very important. Okay. Second thing is that the shoes that you wear, whenever you run, you must wear, or whenever you go for your walk, wear running shoes. Even if you're going for a walk, wear running shoes. Wear shoes which are comfortable, which give good padding. So even if you're running on a hard surface or you're running on the beach, because of the excessive padding, there is going to be a decreased amount of load onto the joint. So all of these small things matter in the long term, and if done well, it prevents the problem. The other thing that you mentioned is cycling. So cycling is a very, very good exercise, because it is not only good for the lower body, but even overall in terms of cardio activity, it is very good. But the thing with cycling is that a lot of people do not know is that when you're sitting on the cycle and your foot goes down, if your foot is on the pedal, when your pedal is at the lowest point, your leg should be almost straight. If you're pedaling and your knees are bent throughout, then you're going to be adding a lot of load onto the knee joint, and that is not good at all. So therefore, you have to raise your seat just adequate, so that when your leg goes down, it is almost straight, not completely straight, but just about 5-10 degrees of bend should be present with the knee joint. And that is a good or a better way of exercising. And as I mentioned, shoes and
Thank you, doctor. I think
office. Yeah.
shoe. Okay, sure. Thank you. I think due to paucity of time, we'll take two more questions and then close the session. So
Okay.
the next one is, how do you differentiate the joint pain due to calcium deficiency versus it being osteoarthritis? So is one question that's come up.
Okay. So see, differentiating joint pain because of calcium deficiency and osteoarthritis is different, because when a patient comes to me with joint pain, and osteoarthritis is usually the diagnosis, for example, it is what has happened and the end result that is seen, while calcium deficiency is maybe the cause of the problem. So they are two different components. Now, the osteoarthritis could have occurred because of age, because of improper footwear, because of flat feet, because of various problems, like I mentioned. And one of them can be calcium deficiency. But again, calcium deficiency does not cause arthritis. Okay, calcium deficiency will cause weaker bones. So, as you also asked me, is what is osteoporosis? That is an indication. Osteoporosis is basically where the bone is weakened right now. Okay, so because of deficiency in the calcium, and as you in women above 40-45 years old, when they develop menopause, they have a deficiency in estrogen and progesterone hormones, which also regulate this. So that causes osteoporosis. But in terms of your question, joint pain due to calcium deficiency versus osteoarthritis, you cannot say that. There are two different components. Osteoarthritis, as I mentioned, occurs either because of some trauma or some problem that has happened, which is secondary, or because of general wear and tear. So if you think you have calcium deficiency, the best thing to do is always get a blood test, and that usually gives you a clearer picture of the same. And osteoporosis is a long-term effect or a long-term problem that has occurred because of constant calcium deficiency. Your bone has now become weak. So that is called osteoporosis. Okay.
So I think the last question for the day, doctor, is you mentioned in your presentation that supplements also are required for actually delaying the process. So is there any age bar from where one should start taking those supplements, or you would say it's post 55 or prior to that as well, one can start taking the supplements? So what's your take on that one?
So a lot of people give different things. A lot of people give something called as a glucosamine and all, but there is no study which clearly indicates that glucosamine supplements help, or even collagen supplements help in delaying or treating osteoarthritis. But supplements, if you're taking, say, supposing your normal vitamins and minerals, I would always advocate anyone above, and if it's a man above the age of 50-55 should take supplements daily, because and women above the age of 40-45 years, I would say, or if whenever they've hit menopause where their normal menstrual cycles have stopped, then they should take supplements. So what happens is, as you grow old, in women it is more so, because what happens is, as the menstrual cycle stops, there's a lot of different imbalance in the normal hormones. Your estrogen and progesterone, which are required for your normal body building and maintenance, decrease, and because of that your bones become weak. So therefore, women after above the age of 50-55, even a small trivial fall, and they slip and fall from the stairs, or they just miss their step while climbing stairs or climbing downstairs, they can have a fracture because their bones become that weak. So for people who are women above the age of 45, or people who have had their menstrual cycles are stopped, I would advise you to take vitamins, minerals, those calcium tablets which come one a day, every day. Okay. Men also above the age of 50-55, because that's when their testosterone hormone starts to reduce, and there are a lot of problems that occur because of that. So if you aren't getting it in your normal food, if you're always better to take it. For the younger people, it's always better to take it as supplements. If you're getting good food, no problems, then not needed to take for the younger people. That's it. And there are a lot of such kind of things in the market which give you the same.
Thank you, doctor. I think.
Yeah, tell me.
Yes, because and in fact, I think there are a lot of different doctors also prescribe it a little differently as well. So
yeah, so a lot of people prescribe.
Thank you so much for your time.
No problem.
Yeah. Thank you so much for your time, Dr. Rishabh, and patiently taking us through what arthritis is, what the kinds of or arthritis that are there, and what is the line of treatment, and what one should be aware of in terms of signs and symptoms. Thank you so much, and pleasure to have you here today, and with our colleagues here. Thank you so much, and all the attendees, once again, thank you very much for making out time and attending this session today. Thank you.
So thanks a lot to you guys. A lot of questions were unanswered. So if anyone has any doubts, as I had given my email ID, you can reach out to the same, okay, or call me on the number, and we can then take it further from there. Thank you. Thanks a lot to RBL Bank also for starting this initiative. It helps in a lot of people, knowing what their regular problems are and how to deal with it. So thanks a lot to everyone involved.